So the summary of this talk will be on the process of tissue diagnosis, going through a virtual tour of our laboratories here at Yale, marrow testing, so focusing on a few key parts of this, sample adequacy, the actual biopsy itself, aspirate, flow cytometry, genetics, all of this comes together as a multi-modality diagnosis, and then disease discussion. So if we have time, I'd like to go through a few case studies of how we get to that diagnosis. Now, the laboratory pathology, we actually process all sorts of tissue samples. So, we're talking about anything from breast cancer, whole breast resections, to pancreatic cancer that ends up having like a block of tissue with pancreas, gallbladder, small bowel, amputations, all sorts of things. So what I'm talking about here is really just a small fraction of what we do, but I do only hematopathology. So I look at nothing else but what affects malignant hematology. And so this is what I will focus on, because I don't ask me anything about breast cancer. I just don't do that. So what we're talking about here is a compilation of samples. The blood draw, which gives you CBC and blood smear, which is on a slide. The bone marrow biopsy, which physically becomes the core biopsy. There can be a touch imprint, which comes in handy if the aspirate is not good. A claw section, which is essentially clotted material at the end of the Jamshini needle after they draw the aspirate, which is more material that we can use. And then the liquid portion of this biopsy, which is called the aspirate. The aspirate actually ends up giving rise to all these other tests. So aspirate smear, flow cytometry, cytogenetics, Fission molecular, that all requires fresh cells that are in suspension versus the biopsy, which is a solid sample. And I'll show you that in a visual way. So on the biopsy, I can also order a lot of these immunohistochemical studies, which is essentially looking at the protein expression of all these cells. So that first part, this CBC, blood smear, the biopsy, the aspirate, the flow, go into the initial diagnostic report, because that can be done in essentially a couple of days. The rest, like cytogenetics, Fission molecular, generally come out in any institution somewhere between 10 to 14 days. So that's why it doesn't come out in the initial report, it comes out later. And just to illustrate that, here is the core biopsy sample. In our jar, there is B+ fixative in there. In other jars, there might be formalin. So there are specific jars that we provide to the floors in order to put the samples in. And then with that kit for bone marrow, there are two tubes for the aspirate, the EDTA tube for the flow and molecular, and then the sodium heparin tube for the cytogenetics. So that gives rise to the triaging of this bone marrow sample. Once it's taken from the patient, it goes to these different laboratories for processing. And this gets combined in my department in pathology. So this is the area where we do intake. So this is the front door of our frozen section room. This is inside the frozen section room. And then behind this room is another door that leads to all our operating rooms. So you can see why it's set up this way is so that when the ORs have specimens for us, they just go right through that door. It goes to frozen section, and we can make essentially a snap judgment on certain cases happening in the OR. Pathologists serve as eyes for surgeons. So when they're taking out a bigger specimen and they're looking at margins, what we're doing is under 20 minutes, and usually it's about 10, 15 minutes, we can do a rapid assessment of clear, not clear margins. But this is also the room where all the biopsies congregate. So everything that ends up in tissue diagnosis will come to this room. I'm not showing the other section of this room, which is a whole table where our accessioners are. So they are intaking the bone marrow sample. And what they're doing is each case, so each little sample will have a barcode. And so once we receive that and it's barcoded, it is tracked with the patient medical record. It is tracked from start to finish. And so we never lose a sample once it's received in this room. We actually have a board with all the tracks. So like we can see at what stage it is. Before we had this electronic tracking, it was very difficult to know which stage the biopsy is at, but now it's actually quite easy. So once it's received, it's barcoded. We know which patient goes with which specimen. It ends up here in the grossing table. So this is usually for us, a pathologist assistant, also abbreviated PA, but not physician assistant, pathologist assistant, even though we're also physicians. But they're specially trained to handle tissue specimens and to sample adequately. These are two jars. One has the core biopsy and the other has the clot section. The accessioner will print out these cassettes, which are little plastic containers with holes through them so that liquids can flow through and fix the sample. And what they do is, so here's a core biopsy. It's very small. We're afraid of it like degenerating and slipping through the holes. That's why we have them put it in a little mesh bag and then place it into the cassette. Then this cassette goes overnight into a processor. The processor starts around 6:30. So we'll receive these cases somewhere between 4:30. It goes into the processor. It gets fixed until it's really stiff through formalin and other chemicals flowing through these cassettes. It's basically lined up on the processor. This is one of our technicians, Tony. She's fixing some of the extra bone marrows in a cassette into B+, which makes them look more sharp on the microscope. And then also special to the bone marrow and not to other things is the decalcification process, because as you might imagine, there's little bones inside our specimen. So when you cut the sample, it's going to shatter the knife and it will shatter the cells inside. So we have to decal it. Our process is about an hour for decal. So say we receive the specimen at 4 o'clock, it gets decaled for an hour, 5 o'clock. It must go on the processor at 6:30 in order to get to the next day slide form, right? So that's, I always try to get the clinicians who are getting the sample to us to give it to us before that time period. Because if it is being decaled at 6, you can imagine it doesn't go on the processor that night, right? Okay, after it goes on the processor, and mind you, I have, as a pathologist, nothing to do with the specimen yet, right? Because it's all the technical part. This is 6 in the morning. Zhang Min, one of our histology technicians, is embedding the tissue. And what that means is there is liquid wax that he is putting into a mold, and then he puts the specimen into the mold here so that he's taking it out of the mesh bag, putting it into the mold, and then it solidifies on a cold block. So he's showing you it's solidified. He puts the cassette back on. So it's stuck back onto the same cassette. And this is the mold. Then what happens is this gets clamped onto this thing here. And then we put very sharp blades mounted onto the knife mount here. And these blades are frequently switched up because they shatter. And you have a lever that I'm not showing here. As you turn this lever, this knife goes up and down onto this block of solidified wax where your tissue specimen is. And so you might imagine it needs to be placed just right. It can't be placed like, up. It has to be placed flat so that we can see the full surface. And that's what Zhang Min was doing with the embedding, trying to make sure that it's oriented correctly. So it goes up and down onto this wax. And what I want them to do on bone marrows is give me 2 to 3 micron sections. So very, very thin sections, almost like transparent sections of wax with a slice of tissue that then they float onto this warm water bath, take a charged slide, scoop it up, and that's where you get 1 slide. Every single tissue has their own protocol. The protocol that I have had them do so far at Yale is to do 2 H&Es that are flanking 5 unstained slides, and at the end, an extra slide for my reticulin stain. So all in all, every single bone marrow gets about 8 sections up front, 8 of these slides. And this is just the blocks on ice. That makes it crisper when they cut it. Then this is the automated process. So you take all of these unstained slides that he's cut off the wax and load it onto this automated slide stainer. Takes about 40 minutes. It gets dipped into these bins that have dye in it. So one of them is hematoxylin and the other is eosin, and there's a lot of water and alcohol fixation in between. The automated slide stainer takes a batch of slides, dips them all sequentially into these bins for times that we've indicated for it. In about 40 minutes, you get unstained slides to stained slides. And this is how we get our actual slides. This arrives to us around 9 in the morning. And this is the outcome. So you get the core biopsy, which just went through that whole process from 4 p.m. to 9 a.m. basically. Class section also went through the same process. And then we get deliveries from the core lab of aspirate and peripheral blood. Sometimes there's touch imprint. And then here's clinical information on a sheet of paper that's associated with that biopsy. And then other stuff is basically coming out of these other labs that I'll get to in a minute. This is my colleague, Dr. Deepika Kumar, who I trained as my fellow a few years ago, and she is now my colleague. So she is actually sitting here. This is around 9:30 when all of these trays of slides have arrived. And this is the initial interpretation of the H&E, the hematoxylin eosin stain. So let me give you an approximate timeline of how this goes from the biopsy to the diagnostic report. It starts here where we receive it, it's grossed, it's fixed, it's decaled, and then tissue processing overnight. It gets embedded in the morning, slide cutting, slide creation, aspirate delivery. That's usually coming out a little bit later. Initial heme path morphology review between 9:30 and 10 a.m. We order the immunostains. There's a cutoff for immunostain ordering, so we try to get it right in between that time. And this gives you essentially a proteomics view of the tissue. So we wait for the immunostains, which come out around 4 to 6 p.m. If the slide that we initially receive is very straightforward and we don't need immunostains, it can be signed out later that day once the flow is done. But if it needs more, like if it's a complicated situation with 2 or 3 other things going on, we'll need more immunostains. So it goes through another day because the immunostaining process itself, which I won't go through, is very long. And then that generates the final report into EPIC. So that's just bone marrow. Every single specimen has its own timeline and its own peculiarities. This is this is one of the most beautiful bone marrow cores in that it's very long and it's got a lot of marrow. Okay, and sometimes we're not so blessed to have such specimen, but the cells are in here where the purple is, and then the pink, that's the bone. Okay, so for adequacy, we really want at least 3 intertrabecular, these bone cells for evaluation. The white bubbles here is fat. And as we age, there's more fat cells and less bone marrow cells. So here's the basic components. We have the core biopsy, which I'm going to assess for the 3 lineages in terms of quantity and quality of maturation. I'm going to look for lymphoid aggregates. A lot of times, these bone marrows are coming to us for cytopenias or for decreased cell counts. And of course, the big question for us is usually, is there an actual neoplastic process with the myeloid component? But sometimes it's actually lymphoid. Sometimes the patient actually just has a lymphoma causing the cytopenias rather than MDS AML. So that's why we have to assess for lymphoid aggregates. There's also looking at cellularity overall, which comes into play for aplastic anemia. And then we do reticulin stains to look for marrow fibrosis, which is another disease process. Aspirate, which comes out as a monolayer of cells. So unlike the core biopsy, which goes through fixation so that it's preserved basically for infinity, it's like really preserved tissue. The aspirate, as you remember, it comes in a tube and we draw from the tube. There are techs that specifically are very good at pulling out spicules of marrow from the tube and smearing it so that you have a monolayer of cells. This is useful because you can really look at the cells up close and personal, and I'll show you some pictures of that. The cytology is great. Unfortunately, it's not as long lasting as a core biopsy. You cannot make additional cuts like we do with the core biopsy. Our core biopsies are kept forever. I have seen core biopsies from 1960. So we have all of these permanently as a part of the medical record. And then flow cytometry and genetics. Now, because as I mentioned, the timeline of these resulting from our interpretation, these are the components that come out in the initial report. This comes out later. So what do we talk about when we say maturing trilineage hematopoiesis? You may see some of that in your bone marrow reports. So actually, if you look from the perspective of the blood stem cell starting out, it's actually bilineage, right? You got myeloid and you got lymphoid, and it gives rise to all these progenitor cells. But when we say maturing trilineage hematopoiesis, we're actually looking from the periphery. So red blood cells, platelets, leukocytes, white blood cells. So even though they have different precursors, they look to be similar when you see the peripheral smear. So those are the trilineages. In greater detail, you have here hematopoietic stem cell going to the progenitor cell, lymphoid progenitor, myeloid progenitor. And lymphoid progenitor becomes B cell, T cell, NK cells. They all fight infections for, in different ways and work together to do that. And then you got the myeloid cells, which really look quite different from each other. So erythrocyte, red blood cell, platelets, neutrophil, eosinophil, basophil, these we call granulocytes because they have granules in them. And then monocytes and macrophages, they're essentially the same cell, but one is circulating in the blood and the other is in tissue. This is what it looks like on the core biopsy that we get at 9:30 in the morning. Okay, this is actually an island of erythroid precursors. So these are the cells that give rise to red blood cells. And they, in normal bone marrow like this one, they actually form islands around macrophages. And then you've got megakaryocytes that often are near blood vessels, giving off platelets from this cloud of platelets that they have on the outer edge. So normal bone marrow actually have architecture that is useful to seeing when it becomes dysplastic, it loses that particular architecture. Also, the myeloid cells in normal bone marrow, they start out near the trabecular bone, and these are myeloblasts, but they're normal. They should be there. As they mature, they go inside and they become these, granulocytes, neutrophils, bands, EOs, and stuff. So this is also part of the normal architecture. Often in MDS, what you'll get is these blasts and other precursor cells going into the middle of the marrow. So now let's break it down. So you got myeloid maturation, where it starts out here as a myeloblast. And as it matures, the nucleus gets smaller. The chromatin, which is the look of this nucleus here, starts out very clear, almost transparent, and gets more condensed as its chromatin gets more wrapped around each other. And then you also have granules in which it's very coarse in the promyelocyte stage, and it gets more and more fine as it becomes mature. We want to know about what stage these cells are all at. And it's one of the kind of beauty of hematopathology is that we can see how the cells are maturing down that stage. So like for other cells, such as epithelial cells, skin and stuff, we don't really know all these stages as well. But for hematopathology, we actually know what the normal is. And hence we can extrapolate when things are abnormal, what stage they're coming from. Erythroid. So erythroid, this is the best schematic that I've seen about it, in which you've got the cytoplasm, which is really, really deep India ink blue, and then goes to kind of a grayish purple and then red when it's a red blood cell with iron in it. You've got nuclear size similar to myeloid, starting out large, becoming small, getting exuded from the red blood cell. The chromatin pattern, you have DNA that's very dispersed and then becomes really condensed. So when you put that all together at the bottom here, this is synchronous maturation. So the nuclear detail and the cytoplasmic detail is in sync with each other. And in MDS, it becomes out of sync. Usually the nuclear maturation has not caught up to the cytoplasmic maturation. And then I won't belabor the point, but megakaryocytes go through a similar maturation process. We don't see that as much because there are fewer megakaryocytes and there are very rare megakaryocytic diseases in adults. It's more often in children. Normal ranges for bone marrow cellularity, this is just a general rule of thumb that it's about 100 minus the age. So when you look at a bone marrow at low power, this is around 30 to 40%. And we're looking at the cells, the purple, versus these bubbles, which are the fat cells, the adipose tissue. So this is about 30, 40%. This is 50%. This is very high at about, over 95%. And that actually has a leukemia in it, which is why it's so high cellularity. Okay. But for reference, we have this here. As I mentioned, we also routinely do reticulin stains on every single bone marrow. Why? It's to look for fibrosis, which can be a neoplastic or non-neoplastic disease, and we grade it for certain types of neoplasms. And here is reticulin that is mild. You can see these chicken wires here. This also causes sometimes the poor aspiration, because when the needle goes in, you can imagine that it would be hard to draw up cells when you've got this much chicken wire fibrosis around it. Reticulin fibrosis is usually reversible until it goes to the end stage, in which it's actually coming with collagen fibrosis, and that would be very difficult to reverse. So, so we grade that to give basically a staging for the marrow fibrosis. And when we report new bone marrow cases, if the patient has prior bone marrows, we would compare that, right? So it's really good to do things in a similar way so that you can have comparisons. And here's more of our chart for grading the fibrosis. This comes into play with certain types of MDS with fibrosis. Here are our immunostains. So I won't go into detail about how immunostains are done because it's quite complex, but essentially the large picture of it is they're antibodies to antigens on the cell surface that identify the cell and also can be targets for treatment because the cell is expressing these antigens. So the antibodies that we have are all conjugated to a brown stain when you look at it in light microscopy. So you might say, wow, they're all brown. How do you know what is what? The technologists for immunohistochemistry, they actually have these different bins and they label it separately. Plus, I can tell because of the cell morphology that these, for example, are megakaryocytes. And then the label of this immunostain, CD61, which is a megakaryocytic marker. So these are megakaryocytes. CD71 is transferrin, which is on erythroid progenitors. So you can see my erythroid progenitors are positive for it. It actually doesn't stain plain old red blood cells, which is nice because I don't want to see it being like an artifact on the slide. And then here's myeloperoxidase, MPO, which highlights the myeloid components. So you can see by this technology that I can pull out cells, even cells that might be hiding in the background, we can smoke them out by these immunostains. You don't always need them because the morphology could be just perfect, but it's helpful when little things are hiding in there. So CD3 looks at T cells. This is the normal amount and distribution of them. CD20, I have actually many more B cell markers than just these three. It's about like 7 now because the scientific community has actually discovered drugs that target these B cell antigens. And hence when they target it, it means that when we look for it, it goes negative, right? So we need to find other markers in order to look for B cell clonality and B cell tumors. So we just get more and more markers as the drugs catch up and target these markers. CD138 is a plasma cell marker. So these are helping highlight the plasma cells. When patients have myeloma, which is a tumor of plasma cells, we use this routinely to show how much myeloma is there. Now we're going to move on to aspirate cytology, which is the monolayer of cells. These are also going to look purple, but it's a different stain called the Wright-Giemsa stain. And for the aspirate adequacy, we need spicules, which I'll show you in a moment. Spicules are actually the marrow components versus the blood components, which will also come out in the aspirate. We're looking at a detailed evaluation of trilineage cellular morphology. We usually count between 200 to 500 cells per aspirate. This is to really give a confident call of dysplasia or no dysplasia, and also the blast count, and also to look at abnormal cell morphology. You'll see why I use this to look for morphology specifically, because you can really get up close and personal with it. In fact, we have 100x oil immersion on our microscope specifically for aspirate. We also do an iron evaluation to look for ring sideroblasts, which is a subtype of MDS. So here is one of my aspirates. It's looking very good. You know, we would compliment the hematologist who did this biopsy because there's so many cells. And this is the spicule here. So this is as close to the marrow as you can get in the aspirate. This would be as close to peripheral blood. So when we do our 500 cell count, we're going to go over here. Okay, we're going to go over here because that is as close to the marrow. But here you can't really count because you can't see anything. It's just doubled up on each other. You can see also the fat, right, of the spicule. Megakaryocytes you can also see in the aspirate, but they're going to be fewer because they often get trapped in the spicule. So we usually look for megakaryocytic morphology on the core biopsy because they're big enough to see anyway. And then we look in detail for the myeloid and erythroid dysplasia in the aspirate because they're very small and you need that 100x oil. At medium power, you can see our myeloid and erythroid cells. You can start doing an overall assessment of their morphology. On high power, and I apologize for so many labels here, some of these slides were taken from my lectures to our residents to get them to recognize each type of cell. You have, for erythroid maturation, it goes from a pro-normal blast, starts out its life as a pro-normal blast after it gets differentiated from a stem cell, and then it goes to basophilic normal blast. So it's basophilic, which is bluish. It goes to polychromatic normal blast, which is kind of grayish, and then orthochromic normal blast, and finally the red blood cell. For myeloid maturation, starts out as a blast going towards promyelocyte, myelocyte with more cytoplasm, band here, and then finally, metamyelocyte, band, and then there's a neutrophil. Here's a neutrophil here. Other cells include lymphocytes, plasma cells. So these are all annotated in our reports, how much of what you've got in this aspirate. And then in the meantime, while we're doing this count, we're looking at, do we get enough dysplasia in any of these lineages? We do an iron stain. This one, for some reason, is historically pink. And the iron is actually called Prussian blue. And it's these blue dots here. When you see this, this is generally someone who has been recently transfused. So just a lot of iron here. And again, we do a semi-quantitative look at how much storage iron there is. And we also look for ring sideroblasts. And there's a specific definition of ring sideroblasts. Now, while it does correlate with a specific subtype of MDS, it can also be seen in certain non-neoplastic situations. Certain types of drugs, copper deficiency, zinc overload, lead poisoning, so this is not pathognomonic for MDS, but it is suggestive of it in the right clinical setting where the patient doesn't have these medical conditions. So we really rely a lot on the clinical history that the hematology takes when they see patients in order to know that these are ruled out or not yet ruled out if the patient is coming for initial visit. Flow cytometry. So here I've been talking mostly about the morphology side of it, which is the looking at cells. Now I'm going to just briefly touch upon flow cytometry, which is a immunophenotyping, kind of like immunostains, but immunophenotyping of single cells. So this really only happens in hematologic diseases, because in solid diseases, like say you have stomach cancer, it doesn't easily go into a single cell suspension. Okay, so that's why we don't use those tissues for flow, but we use heme tissues for flow because it goes into a single cell suspension. It's also why, I should say it's not like all heme malignancies, because Hodgkin lymphoma and some other lymphomas may not flow well either, right? So it's specifically for heme diseases that flow well. So here you've got a cell suspension. And what happens is very early in the morning, they are incubated with various antibodies, just like what I said about immunostains. But now these antibodies are conjugated to fluorophores of different wavelengths. Okay, so they're incubated with that. So a cell that has a lot of CD20 expression, a B cell, will emit this wavelength when it goes through the chamber. So it goes through this chamber, the laser hits it, and there's a forward scatter of the cell and a side scatter of the cell, telling you how large and how complex the nucleus is. And then there also is the part where you see the fluorescence of these different antibodies to the cells, and it gets collected, and what results is this. So we interpret that as well. Here is CD45 against side scatter. So it splits out these cells very well. And this is actually the kind of technology that is used in the CBC as well, right? So you have lymphocytes here, which is high on CD45 and low in complexity, which is what side scatter does. You have granulocytes, as you know from the morphology of the neutrophils, they're highly complex. They've got granules in them. So they are very high complexity when they are mature and low complexity when they're immature. And so you've got monocytes here that are in between. Then these are the antibodies, so CD19 for B cells, kappa and lambda, which are light chains. So in a normal patient, you would have, almost equal amounts of CD19 positive, kappa positive cells versus CD19 positive, lambda positive cells. And they kind of switch like this. And if you've got a clone of B cells, usually it's one or the other. So you'll see a big cloud in kappa, but nothing in lambda. So that's how we can analyze flow cytometry. So genetics is complex in terms of its testing, because you've got, here's a chromosome, and we got 46 of these chromosomal abnormalities at large levels. So translocations, rearrangements, large deletions, and additions are assessed by karyotyping. And then you get ever finer detail here. So down this road, you've got array CGH, which looks at amplifications and deletions of certain genes. And then NGS, which is sequencing, which can actually show single nucleotide variants, indels, which are insertions and deletions of, just 4 base pairs maybe, and also smaller translocations. But as you can imagine, it's not saying that more detail is better. Sometimes you want to look for large abnormalities. Sometimes you want to look for small abnormalities. And then in orange here in this schematic, what I like is in the orange, you've got things that are like the microscope, where even if I didn't get a question from Dr. Zeidin or Dr. Stahl, I would be able to find something, right, just by looking at it. Versus in the green here are assays in molecular, which are probing a specific abnormality. So you have to have a question in mind, just like flow. You have to say, oh, I want to look for how many blasts there are. I want you to look for B cell clones. So for fish, it's like saying, I want you to look for a deletion in 5q. So then there will be probes to that. Okay, so these are all looking for specific abnormalities. That is helpful in certain instances. And these are looking for kind of overall, let's see what you find. So this is a karyotype, and this is the banding that results from each cell. Each cell has these this complement of karyotype. In a normal cell, you have XY here. This is a woman. And actually in the days when I was training, we actually printed these out on paper, cut them out, and put the bands together. I'm not a cytogeneticist, but we had to go through this training to see how it's done. And it's also a morphologic inspection of are there bands that are missing or added or switched up. And it is actually quite difficult, but the cytogeneticists are trained to see, what is normal and abnormal from these karyotypes. And then here's fish, which I talked about just recently about the 5Q. Here's a green probe and a red probe. The green is on the short arm of 5, and then the red is on the long arm. And you can see that if you had a deletion here, you would have a 5Q loss. So here you have 2 green and 1 red. And usually cytogenetics likes to count 200 of these cells to be sure that what they counted is correct. Okay, I'm going to try to speed up a little bit more because I see that I'm okay. Okay, great. Thank you. So molecular NGS. Now this part is the very fine detail look at genetic abnormalities. And there are many different ways to do this, but they all go through some basic steps. So you have sample prep in which DNA is fragmented and adapters are added to the ends for unique molecular barcodes. Then it goes through cluster generation. So this is a particular technology, this is a flow cell. These DNA fragments with the adapters on them go onto this plate essentially, and each fragment is hybridized to the plate and amplified. So here's a fragment of DNA that is getting hybridized, and it will get amplified and bridge again to have a cluster of DNA that is all onto this plate. Then what happens is the sequencing part where individual bases are read as they grow on a template strand. And as, like, let's say this A base gets added, it will emit this light, and this is detected optically. And finally, when all this information is put together, this is massive parallel sequencing, by the way. So many patients' samples can be loaded at the same time, but somehow it gets sorted out because of these unique molecular barcodes. Then the data analysis happens. So all these fragments get lined up together to reduce error, and it gets aligned to a reference strand. And this is probably the hardest part, where you have data scientists looking at which section is abnormal and how much of it is abnormal. And this gives you the NGS result. By the way, if you're interested in the video of it, there's a link right there. That's one of the instruments that do it. But again, testing is complicated because you want to choose the right test. PCR is not out of date because it still gives you a very, very low limit of detection. And it's quick, it's high sensitivity for the known mutations, it's low cost per sample, and you can get absolute quants by some methods. NGS, you don't need to know any prior knowledge of the sequence. You can find novel variants, although what you might do with it can be unclear. And it can detect multiple mutations at once, a single nucleotide resolution. So there are reasons for using. This would give you better follow-up, especially if you have high suspicion. This would give you a better screening test if you don't know what you're going into. So let's just go through a few cases. So patient 1 is a 49-year-old man who presents with fatigue and easy bruising. He has striking pancytopenia. His bone marrow looks like this. And this is the reality, right? Like I would be really happy to get long cores every day, but this is the reality. Sometimes it's much smaller than would be optimal. But here you can see that the cellularity for a 49-year-old man is really, really low. Okay, he should be having about 50, 60% cellularity. This is about 10% or less. On higher power, you're really not seeing megakaryocytes. There are no erythroid islands. There are no myeloid cells maturing inward. So this is very, very hypocellular. You can just see red blood cells and some stromal endothelial cells here. The aspirate is still adequate here because you can see maturing myeloid and erythroid elements. I can't say trilineage here because I don't even have megakaryocytes. There's no dysplasia in the aspirate. The flow shows no increase in myeloblasts, but the flow also says, this doesn't have the usual myeloid maturation pattern, and it's likely hemodilute. So the final diagnosis here would be a markedly hypocellular marrow showing maturing myeloid and erythroid elements. Pertinent negatives are always mentioned: no acute leukemia, no high-grade myelodysplastic syndrome, no lymphoma. And a note that if this is truly representative of marrow status, and there are many reasons why it might not be representative, then this would be most suggestive of aplastic anemia or bone marrow failure syndrome with a correlation suggested. So the correlation comes out about 2 weeks later. You have normal karyotype, FISH probes or NGS is negative, but the NGS panel finds pathogenic variants in BCOR and TET2 at a low variant allele frequency. What do we do with that? Well, actually, this is actually quite compatible with aplastic anemia. These are known variants that are seen both in MDS and in aplastic anemia. So it becomes a really put that picture together, right? You could say, if you just look at that myeloid gene panel, oh, maybe you have MDS. But one, there's no dysplasia. There's no increase in blasts. There's nothing clinically that would suggest MDS. So this is actually aplastic anemia. I'm going to just leave that to some of the people who are going to speak on aplastic anemia later, because I want to focus more on the testing, and I see I'm running a little bit out of time here. But basically, primary and secondary aplastic anemia has its different etiologies. Mostly what we're seeing is idioplastic. And here are some shared mutations between MDS and aplastic anemia. There is also some overlap with somatic mutations that occur naturally with age. And there's actually some studies that show there's improved prognosis for certain aplastic anemia patients with these particular mutations. PIGA mutations, of course, you know from PNH, and there is that connection between PNH and aplastic anemia, so that makes sense. Patient 2 is a 58-year-old woman with dark urine that comes and goes, otherwise fine. What is part of our basic workup? This, I depend on our hematologist here to work up no other sources of bleeding, that the peripheral smear is essentially unremarkable, iron levels are fine, vitamin B12, folate is fine. So the next diagnostic procedure here, given the clinical history, is not a bone marrow, is a peripheral blood flow. And here we're seeing, oh, it didn't come out well, general gating. So each dot represents a cell essentially, and we're looking at the, we'll just focus on flare here. We're looking at the amount of flare in the granulocyte gate and the amount of flare in monocyte gate, for example. And granulocytes have very high cytoplasmic complexity and more CD33. So that's how we identify them. Oh, thank goodness it came out okay on this one. But here we have the patient versus normal. And you can see here that, I'm sorry, these images got kind of screwed up. But essentially when you have the patient erythroid cells, you would have, sorry, granulocyte cells, you'll have this shift. You have an extra population here that is CD59 negative or reduced, okay? And then here you have flare, and you'll have the patient PMN with the flare reduced. And flare is actually this protoxin that binds selectively to the GPI anchor. So this is the linker between the cell membrane and that antibody or the antigen. I don't know why this is coming out this way, but maybe it's a MAC to PC issue. For erythroid cells, you have glycophorin, which is on all erythroid cells, and CD59 again, which is a complement-mediated antigen. And you have in the patient, there'll be this extra blob here, which is CD59 negative. So the diagnosis here is read out quantitatively. You have 17% of granulocytes that are CD59 negative, flare negative, and 7.8% of red blood cells that are glycophorin positive by CD59 negative. And these represent 2 abnormal cell clones consistent with PNH. The underlying physiology is mutation in a somatic mutation in the PIGA gene. And that product basically means that your linker is dysfunctional and the complement protein CD55 and CD59 are reduced on those cells, making them susceptible to complement destruction. So why do we do this functional test rather than a genetic test for PNH? Because it helps to quantify the presence of the clone that's actually abnormal. Normal individuals can actually have the mutation in PIG-A, the somatic mutation, but without functional consequences. So you don't want to just be sequencing PIG-A for everyone, because I might have that mutation, but I don't have PNH functionally. It's also just easier and cheaper to have one flow assay setup than multiple sequencing reactions. And again, I'll leave this to my colleagues who do the therapies and long-term sequelae, which are many. In order to get to this final case, this is a 74-year-old man with anemia and thrombocytopenia. And this is a bone marrow that is hypercellular for his age. And even at low power, you can see that the megakaryocytes are markedly increased and dysplastic. So they have hyperchromasia, small hypolobated nuclei. You can see here that they're all clustered together abnormally with dysplastic morphology. The myeloid to erythroid ratio is also off. That should be 3:1, but the erythroids are predominant in this bone marrow. CD34 is our blast marker. So you can see that these are increased in the bone marrow. This is the brown stain that highlights the blast. It should be less than 5%, but in this patient is 5 to 10%. The aspirate shows dysplasia in the erythroid lineage. You can see here bilobed erythroid cell and dysynchronous maturation here. You can also see in his peripheral blood pseudopellular neutrophil, which is also dysplastic. It almost looks like a Ray-Ban sunglass, and it also has hypogranularity. So we put that together. The flow blast count is also a little high for flow, which is 5%. The blast count on 500 cell count is 7%. So when we put all of that together, this is compatible with MDS with increased blast. And then we specifically say with excess blast 1, which is the WHO diagnosis from the WHO4 revised. Cytogenetics comes back. It is complex karyotype, and molecular comes back with a pathogenic variant at ASXL1. And this could also be plugged in to a risk stratification calculator. The classification has been changing in hematopathology, and we won't have time to go into that now because I just gave 2-hour talks on this at a national hematopathology meeting. And so this is actually showing you this movement of MDS-EB1 and how it is subclassified. Essentially, this patient's diagnosis will remain about the same. It is MDS with excess blast. And we had a review paper that Dr. Zaiden actually pushed us to write, in which you can see how these categories are shifting because of the increase in scientific data that we're getting. This is more about the classification. And so I hope that you get from this talk some key components of tissue diagnosis. Specimen adequacy, which is really critical to getting a good diagnosis, choosing appropriate tests, the fact that we have multiple modalities in hematopathology to put together into one comprehensive diagnosis that detects a spectrum of diseases. And because of the complexity of hematopathology classification and workup, it is really important that those who interpret the biopsies have had subspecialty training and give you that very specific diagnosis. So thank you so much for your time. I want to open it up for questions.
We have a question. The question is, I was told at my last bone marrow biopsy that I had a dry marrow. What does that mean?
Yeah, great question. So I think what is meant by that is dry tap marrow, which means that they weren't able to get a good aspirate for the liquid assessment of the bone marrow. I think you would want to confirm that with the hematologist, but usually that is due to some underlying marrow fibrosis that they can see with the reticulin stain, or it was just the if there is tumor in there, that could be one reason why it is difficult to pull from the aspirate. So there are many reasons for it to be a dry tap, but what ultimately it results in the diagnosis is you only have the core biopsy diagnosis and not the aspirate part.
Yeah, actually, I do see that two things which I think important for patients. One is why do we generally want to have it for patients of other institutions or have it done somewhere else to be reviewed by our own pathologists? Why is that important?
Mhm.
And the second thing is to touch on the classifications and how the records might have two different diagnoses based on
Yes.
classification.
Mhm.
I think that's
Yeah, thank you so much. Those are really excellent questions. So the first one, I know we've talked a lot about how to make sure that patients coming from referring centers or just moving to see an oncologist here, it needs to be re-reviewed. Now, one thing, there are actual studies out there that I would like to reference, but obviously I don't have it here. There are really great studies looking at the discrepancy between hematologic diagnosis specifically. Because it is so challenging and complex, there's often discrepancy as in the diagnosis at the local hospital might not match the diagnosis at an NCCN referring center. And many reasons for this. Primarily, I would say sometimes there is a lapse of time. So more clinical information has accrued, more molecular information has accrued. So there's a difference. But other times it's because there was not a subspecialist looking at that biopsy at the original institution. And there is just so much to know now in the sphere of hematopathology that we really think a subspecialist need to see this. Now, you can't mandate that for all hospitals. That's just not how our country works, as you know. So when you go to a subspecialty center, you might have a different diagnosis. That is why we work together to make sure that the diagnosis is correct, either by reviewing the initial biopsy, or if the initial biopsy did not have all the testing done, specifically the testing that requires fresh tissue, then a repeat marrow might be necessary to get you all of the molecular genetics, the flow, the other testing modalities that I showed that required fresh. Now, for the biopsy that was transferred to Yale, I can still request the tissue to do extra immunostains. So that is still possible. And we'll do that, but that requires some time, as you might imagine, because we need to talk to their team over there, get the block transferred. And so that's one reason why the consult diagnosis would take longer than an in-house diagnosis. And if the disease is rapidly evolving, I trust that Dr. Zaiden would just do an extra biopsy rather than wait 2 weeks for this tissue to hopefully come from another institution. The other question that you had was regarding the classification system. And I'll say that, you know, even though it is very frustrating for practitioners to deal with, I do think that there are more similarities between the classifications than there are differences. And it is in its spirit to give patients more ability to go onto different clinical trials for these myeloid diseases. There's a lot of overlap between the myeloid diseases and their stages. And so that is the ultimate rationale for it. And we are actually working actively to try to harmonize these classifications. Thank you. Just gonna escape out of this.
Thank you so much, Dr. Shu, for sharing your time and your expertise with all of us today.